Good afternoon, dear colleagues. My name is Sara, and I'm from Portland, Oregon. I studied in Debrecen years ago, and I work in a cardiology hospital. I would like to thank my supervisor, all of the translational medicine teams at Semmelweis University, and my vision is introducing innovative approaches in medicine through translational research from bedside to bench and bench to bedside for my patients all over the world. And the mission is collaborating with Semmelweis University, cardiovascular medicine as a national leader in the health for the purpose of improving the health and well-being of the Hungarians and beyond. I have a clinical questions about the leadless pacemaker, and my methodology is as following: intracardiac leadless pacemaker, long-term safety over traditional pacemaker. It's a systematic review and meta-analysis. And the second one is the real-life patient selection and indication of the leadless pacemaker, and it's an international survey study. As a background, the leadless pacemaker is less invasive with the fewer complications. And the primary advantage of the leadless pacemaker is elimination of the several complications associated with conventional pacemaker and leads, including pocket infections, hematoma, lead dislodgements, and lead fractures. 90% is smaller than conventional, and it has a cosmetic appeal. And the future of the leadless device technology is promising, and one beneficial application of the leadless device is in the post-TAVI patient. This is a future perspective of the leadless pacemaker that, as you can see, we use the combination of the leadless with the conventional pacemakers. So in the first projects, the pacemaker-related infection is one of the most costly complications and has a very high mortality rate, 30 to 35%. Cardiac tamponade during and after the leadless pacemaker implantations is a high-risk complication, and the pacemaker dislodgement in pacemaker-dependent patients may lead to the fatal outcome. Leadless pacemaker were designed to reduce lead-related complications, and articles suggest that it may be associated with reduced infection rate, dislodgement, but high tamponade rate. That's why the systematic review is needed. Our clinical questions is that the leadless pacemaker use associated with a different rate of the mortality, complication, and revision compared to the conventional pacemaker. And our PICO, or population, is patients who needs a pacemaker for right ventricular pacing, and for our comparing to the leadless pacemaker therapy patients, and our control group is conventional pacemaker therapy. And our outcome is all-cause mortality, complication, revision, infection, and cardiac tamponade. And our hypothesis would be that the leadless pacemaker has less complication than conventional pacemaker for right ventricular pacing. We used the following databases on November 2nd, and we used this search key. And we found 22 full-text articles that were comparing leadless with the conventional pacemakers. We used the time period of 1 month, 6 months, 12 to 24 months for comparing the leadless with conventional pacemakers. In the case of 1 month of the complications, as you can see, the heterogeneity is 97%, and odds ratio is 0.58, and we have 42% less complications in the favor of leadless pacemaker. In 6 months complication rate, our heterogeneity is 0%, and odds ratio is 0.85, and we have 15% less complication in favor of leadless pacemaker. In 12 to 24 months of the complication rate, the heterogeneity is 24%, and the odds ratio is 0.29, and we have 71% less complication in favor of a leadless pacemaker. 1 month of complication rate, the heterogeneity is 57%, and odds ratio is 0.29, and we have 71% less infection rate in the favor of leadless pacemaker. And the 6 months of the infections, the heterogeneity is 0%, odds ratio 0.38, and the infections, so we have 62% less infection in favor of leadless. and 12 to 24 months of infections, we have heterogeneity of 56%, and the odds ratio 0.24, and we have 76% less infection rate in favor of a leadless pacemaker. So the strengths of our study is for some of these outcomes, we managed to pool lots of patients, 10,000 patients. There are all from direct comparison studies. And the limitations, they are all observational studies, and some of them imply the historical cohort, and strength of evidence is not that high. And the conclusion is, in the first months, there is no difference in overall complication rate between leadless and conventional. However, this observation is dominated by one study. In the midterm follow-up, 12 to 24 months, leadless pacemaker seems to have less complication compared to conventional, and leadless pacemakers show a lower rate of the infections in all comparisons. And our clinical implication for practice would be the patient with high risk for pacemaker-related complications and infections should receive leadless pacemaker, because leadless pacemaker has lower complication rate in the midterm follow-up and lower rate of the infection compared to conventional. And the implication for research would be more studies are needed, if possible, in the form of randomized controlled trial. And our progress is at the level of the internal review and language editing, and our target journals are JAMA Cardiology. And our second project, which it is international survey study, the background would be the leadless pacemaker reduced major complication by 63% compared to conventional pacemaker. Per a survey in Europe in 2018, high cost of the device was the main reason that not using the leadless pacemaker. And 72% of those surveyed anticipated that an increase in the utilizations within the next 2 years. And that's why this is a reason to reassess. And our clinical questions is that which patient population served better by leadless pacemaker versus conventional? And what are the major barriers that patients do not receive leadless pacemaker? And our aim would be to evaluate real-life patient selection for leadless pacemaker implantation, identifying major causes which prevent the widespread use of the leadless pacemaker technology. And the hypothesis would be the high price, awareness, insurance company coverage, and training and knowledge of the cardiologists that using the leadless pacemakers would be the major barrier. And our technical points would be that we made a self-made questionnaire, and we are distributing it in the network of the Arrhythmia societies. And it's in the level of the distributions in the Arrhythmia Society during the September. And this is a summary. And for my personal quote, one of my hobbies is writing the poems. And I wrote these poems to dedicate to all of us, and all of the healthcare workers, all of the physicians, and all of the beautiful human beings that with their gestures and actions, they promote unity, love, care, compassion throughout their lifetime. And my poem is a time in our lifetime, celebrating light and life in the heart of the night, bringing life, hope, and joy for all hearts in pain. Wonders at wondering, we have a universe in our hearts, and we are all one hearts in the universe. Thank you for your kind attention.
I would like to know, how did you measure the complications, if there was any severity scale, or did you focus on complications only, just maybe admission at ICU, or which complications were these?
Thank you for your questions. Basically, in different articles, they had a list of the definitions for complications. So we matched all of these definitions together because it was in the chart base. So they were defining that we mean complication based on these definitions. And we just collected the data based on the matching between that articles.
It's very difficult to differentiate among the centers that use different scales for the complication rates, and it's very important to know that the leadless pacing does not have a pocket, and there are lots of pocket-based infections in the implanting centers as well without any infective endocarditis. And it's completely different as a complication from the leadless pacing because there is no pocket infection, there is no device inside, just under the skin, there is only a device inside the heart. So it's not easy to differentiate or to compare these two parameters. My question would be such like this one. Are you aware of the training level of the centers who have published these articles? Because it depends on whether the complication rate depends on the learning curve or the trained level of these physicians who implant even the transvenous traditional pacemakers or the leadless pacemakers, because I will just go special training for the leadless pacing in the future as well, but it has several steps to be eligible for implanting one, the first one, second one as a second operator, for instance, just to decrease the complication rates. So let's get back to the centers. Are you aware of the training levels of them, of the paper authors?
Thank you very much for your wise question. Actually, based on my comparison in the articles, I realized that for sure, for example, in Japan, if they do it, they did a good job, but I'm not personally sure how much they are trained, but maybe their populations, patient populations also is indicative. Personally, I don't know about the training level of those. And the year, the spectrum of the year that they were publishing also means a lot, because I think as earlier as they published, they have less knowledge or less training, but as much as advanced, like in 2021 or 22 or 20, they are more trained. So this is also, I think, important.
Yeah, it would decrease the complication rates as well.
Yes.
So it will just influence the outcome of the meta as well, if you do it 2 years later again.
Yes, exactly.
Potentially, yeah.
Yes, I just have two remarks before asking ugly questions. One is the training level. Most of the studies started the data collection at the very beginning of the leadless pacemaker experience, and most of the centers had already a big experience with conventional pacemakers. So that is not the same training level. So training is relatively low in leadless and relatively high in conventional pacemaker, and still there is a difference that favors the leadless pacemaker. The other point is, in the last few days and today I just got the report that a true randomized study is planned, which will compare conventional and leadless pacemaker. We were awaiting this study because this technology is available for 8 years now and still no true randomized studies. So it's under planning, but it will be very difficult to compare the leadless single chamber pacemaker with conventional DDD pacemaker. One question: what could be the reason behind the relatively low infection rate on the leadless pacemaker side?
So obviously, because we don't have pockets in leadless, so it's directly implanted inside the heart. So we are just bypassing that lead-related infections that we have in conventional pacemaker.